Radiographic interpretation of dental caries. So caries is a multifactorial disease process which has interaction among three factors: the tooth, the microflora, and the diet. So all of them starts with the formation of a biofilm, the intake of fermentable carbohydrates in the diet. Caries is an infectious disease which causes demineralization of the tooth surface. The initial carious lesion, they appear clinically as chalky white spots, indicating there is activity of carious process taking place in that region, or it can be opaque or dark brownish spot, indicating that it is a period of past active caries. A lesion beneath the active bacterial plaque will progress slowly or quickly, but if the biofilm is removed or disturbed, the lesions can arrest by itself. The disease mechanism occurs as follows. There will be demineralization, which will extend into the dentine before a breakdown of the outer surface, that is cavitation in the enamel, occurs. So what is the role of radiography in detection of carious lesion? The lesion is seen in a diagnostic image as a radiolucent, that is darker zone, because the demineralized area of the tooth does not absorb as many X-ray photons as the unaffected or intact tooth structure. So always the demineralized area will have less amount of calcium phosphates. So they are going to offer less radio opacity or more radiolucency in that area. As you can see in the image, where there is demineralization, it is more radiolucent. Where there is no demineralization, that is no carious activity, it appears radio opaque. So even an old or inactive lesion, that means clinically it is arrested, can occur as a scar in the hard tissues. That means it is radiolucent still in the hard tissues because of the demineralization which has taken place. Now, the diagnosis of caries should be both clinical examination and X-ray interpretation. The caries can be classified generally as pit and fissure caries, which occurs on the occlusal, buccal, or lingual pits; smooth surface caries, that is the proximal, buccal, or lingual surfaces and the root caries; and the recurrent caries. So radiographs needed for caries detection, you can use the periapical radiograph, especially using the paralleling technique, because it gives you more accurate details. If you are using a periapical radiograph, you are going to see the changes around the root and between the teeth as well. The Bitewing Radiographs are indicated when the symptoms suggest that there is no involvement of the pulp. If it's a carious lesion, the patient's symptom will be specific to sensitivity. But when the pain is involved, then it is better to indicate a periapical radiograph. So these Bitewing radiographs, as you know, it is indicated for detecting the interproximal caries. And if you suspect that the interproximal caries has gone deep to inflame the pulp and cause a periapical tissue damage, you can advise for a periapical radiograph. Now, panoramic radiographs, they are not used to view or detect caries because of the resolution of the resultant image as in extraoral film-based imaging. In the case of digital panoramic radiographs, we have some limitations like overlapping in the area of the premolars, especially anterior region. It cannot be diagnosed because of the overlapping of cervical vertebrae. So all these are going to be a drawback to diagnose caries from panoramic. So usually it is not done with the help of a panoramic radiograph. You can see the gross picture of the whole amount of dental conditions in the panoramic radiographs. That's why it is called as a screening radiograph, to understand which all areas you need further evaluation. Occlusal radiographs, it is inappropriate due to the angulation it makes it with the teeth. So in the child where you have shorter roots, shorter teeth, you can use anterior occlusal views for detection of caries. Also, the contact points in the anterior teeth of the children, they are quite open, so we can see the presence of any interproximal carious activity. So the frequency of any radiographic procedure in a patient with caries, it depends upon the patient's oral hygiene, the fluoride exposure, diet, caries history, and the age of the patient. So criteria for adequate Bitewing radiographs, it should be properly exposed, it should be properly projected with a good horizontal angulation, and of course with a vertical angulation of 10 degrees as well. So, for bitewings, premolars should be positioned a little bit anteriorly so that the mesial regions can be covered, as well as for the molar projection, it should be sufficiently posterior in the mouth to demonstrate the distal surface of the last molar. Interproximal contact areas should never be overlapped, and it should demonstrate open contacts. No other errors should be there when you do the diagnosis for interproximal caries, especially like a cone cut or decreased density. So you can see the properly acquired premolar and molar bitewing in which the contact points are clearly visible and there is no overlapping. You can see the position of the sensor, how it is to be placed for the premolars and how it is to be placed for the molars. Radiographs. For the radiographs for detection of interproximal caries, bitewings are the ones that is used, and for the periapical, you can use the periapical films, that is size 2 in adults and size 0 in children or pediatric patients. So if you have a constricted jaw size, you can still use size number 1. So there is a lot of discussion about the speed of the film, whether we should use D, which gives you more clarity, or whether you use F, which gives less exposure to the patient. But with the advent of digital imaging, we have 80% reduced exposure than the normal film-based imaging. So proximal caries, approximately 30 to 40% of demineralization is required for radiographic detection of a lesion. That means unless there is demineralization of 30 to 40% of that area on the tooth structure, you will not see it as caries in the radiograph. So always remember, the actual depth of penetration of a caries is deeper than what you see clinically and what you observe radiographically. Factors affecting the appearance of caries are the buccolingual thickness of the tooth, two-dimensional film. So they can obscure or hide some factors, like you cannot differentiate the buccal side and the lingual side. So it is a two-dimensional view radiographs. Factors affecting the appearance of caries, they are X-ray beam angle, the horizontal and the vertical angle, the exposure factors. So if you lower the kilovolt potential, the caries detection rate increases because it gives a high contrast in this region by 2. That is what you are actually looking at. So let me show you the pointer. So here you can see the thickness of the enamel, and you can see that the area here, it is less than half of the enamel. So when the caries involvement in the proximal surface is less than half of the enamel, you can say it is incipient or stage 1 or early caries. If it goes more than half, you say it is a moderate caries. If it goes beyond the dentino-enamel junction, we say it is advancing. So unless fairly large, the interproximal caries in the posterior region, they require radiograph for diagnosis. The early lesions especially. So the interproximal caries, as we discussed, up to half of the thickness of enamel, we call them as incipient caries. So in this radiograph, you can see that there are some incipient caries on the mesial aspect of the second premolar and the distal aspect of the molar. So here you have the incipient caries, which is marked by slight discoloration within half the thickness of the enamel. The next ones, we can see the incipient, moderate and the advanced caries. For example, the white arrow indicates incipient caries because it's less than half. The yellow or the pink one, it shows that there is full thickness of the enamel involved, so it is a moderate one. And advanced because these carious lesions on the enamel, they had progressed beyond the DEJ, dentino-enamel junction of the patient, and is spreading inside. So more than halfway of the thickness through the enamel up to the DEJ is moderate caries, as we can see in the image again. In the enamel, there is full thickness almost of the enamel that has been involved with the caries, which makes it moderate. Now, moderate interproximal caries. There are three radiographic appearances. One is like a triangle, other is like a diffuse radiolucent image, and third one is a combination of the two types. So the moderate caries, it can be of any of these shapes, either a triangle shaped, a saucer shaped, or a combination of both of them. So approximately almost all the carious lesions that you see in the patient's dentition, you have to classify them into incipient, moderate, advanced caries. The word advanced itself, it means that it is advancing beyond the dentino-enamel junction to halfway through the dentine. So what is a severe caries? It means that there is involvement of more than half of the dentine, which means the pulp is likely to be inflamed in severe interproximal caries. Like the one that you see here, there is full thickness of enamel involved, DEJ has crossed, dentine has been involved and is very near to the pulp chamber. Occlusal caries. So they must have penetrated into the dentine, but they can be diagnosed from the clinical examination as well. So it can be seen as thin radiolucent line or a cup-shaped zone underlying the occlusal enamel, but it's difficult to see on radiographs unless the lesion is larger. So sometimes it feels that a sharp explorer used to forcefully may contribute to spread of caries by opening up the pit and fissures. So occlusal caries is usually triangle in shape. The base is towards the dentine and the apex is towards the enamel. So you can see the occlusal caries, but you are not able to differentiate whether it's on the buccal or the lingual aspect, which is one of the limitations of two-dimensional radiographs that we use. Buccal and lingual caries, they are at the region of the hard tissue structures as well-defined circular area in the middle of the tooth. So it is usually not apparently radiolucent, but it can be seen. But the differentiation, whether it's on the buccal or lingual side, you have to correlate that with the clinical examination. Root caries, any caries which is forming in the cervical region of the tooth from where the cemento-enamel junction ends. Any caries in that area, it is a root caries. It's usually saucer shape like cratering on the roots of the teeth. They're found especially in elder individuals with the prominent recession and periodontitis. So sometimes they may also be having xerostomia due to the medications that are used for blood pressure, diabetes, and other systemic conditions. So you have to differentiate this always with cervical burnout. Recurrent caries, as the name indicates, it recurs. So you have laser restoration in a patient, and if the patient comes back to you that there is still pain after a few months, that means that there can be some caries process taking place. In the radiograph, when you see there is a restoration and beneath the restoration there is caries, it's called as recurrent caries. So metallic restorations often hide these kind of caries. So clinical examination, pulse status, whether vital or non-vital, is also important for the recurrent caries. So the location of the caries lesion should be related to a restoration, and the angulation should also be right for a biter, that is plus 10. The teeth undergoing the caries activity are more in number than a normal caries. The central incisors of the mandible need not be infected with caries. If it is infected, it is called as a nursing bottle caries. So here, especially in the children, when there is rapid progression of caries, just check the cause of the caries by taking a proper history of the patient. So rampant is for rapidly advancing caries. Next is radiation caries. So radiation caries, it occurs in patients who has undergone radiotherapy. So when you take the clinical examination or history of this patient, they will say about the radiation therapy, which is usually done for the head and neck cancer. One of the side effects of radiation therapy is shrinking of the salivary glands, or you call it as fibrosis. So here, this is going to lead to xerostomia, that is dryness of the oral cavity because of decrease in salivary flow. So fluorides can be used in such individuals to control the caries activity. In the caries, you have to also know about computer aided diagnosis and computer assisted design as well. So automated computer aided diagnosis means that the computer does the evaluation. It's like the artificial intelligence. The computer evaluates the condition and gets back to you with a diagnosis. In the case of computer assisted diagnosis, it is used for both medical and practitioner, and it is a valuable aid to evaluate the radiograph to reach a diagnosis separately. Okay. So treatment considerations depend on the area which has been involved, whether it's in just the enamel or in the dentine. Okay. So that's all for the dental caries. Thank you for watching.